Welcome to Breastfeeding with Confidence. Thank you all for coming to join us for this class. We're delighted you've taken the time to come and learn about breast or chest feeding, and we have hopes that there's something in this class for everyone, whether you're a breastfeeding parent, a support person, a non-birthing parent, or caregiver, if you've given birth or are still pregnant. We're happy you're here, and you're welcome to come back at any time to review the video. We want to remind you that all the resources and links for this class are located in the initial auto-reply email that you would have gotten by emailing breastfeedingzoomclass@iwk.nshealth.ca. In it, there are links to videos and useful resources. They'll also be located in the comments below. We want to acknowledge that the IWK serves a diverse population of patients and families, and we're working hard to provide culturally appropriate care to everyone. This includes the effort to use inclusive images and terminology in our course materials. At times we may use breastfeeding as our terminology, but please know that we're referring to breast or chest feeding for parents, depending on their gender identity, pronoun preferences, and their chosen language for feeding. We'd also like to acknowledge the indigenous wisdom that exists surrounding breastfeeding and birth, much of which was stolen through the genocide that was residential schools, colonialism, and destruction of indigenous family structure. It is our hope that through truth and reconciliation, that wisdom can once again exist and be passed on through for new generations of indigenous birthing persons and their families. So welcome. We're really excited that you're planning to chest or breastfeed your baby. This is one of many important decisions that you'll end up making for your family. The World Health Organization recommendation for optimal infant health includes early initiation of breastfeeding within the first hour after birth, and exclusivity for the first 6 months of life, followed by introduction of nutritionally adequate and safe complementary foods at 6 months, together with continued breastfeeding up to 2 years of age and beyond. There are a number of things to consider when choosing to breastfeed your baby. First off, what makes breast milk so unique and amazing? Well, it's a living fluid that is custom made for your baby. It contains antibodies to protect against illness, hormones that promote bonding and regulate baby's appetite, stem cells that may promote healing and support organ development, white blood cells that fight infection, and beneficial bacteria to protect the digestive system. It's free. It can be upwards of $4,000 per year to formula feed a baby, and breast milk is always free and accessible. When thinking about health benefits or risks, it's helpful if we start by discussing that breastfeeding is a biologically normal way to feed a baby. So that is the standard for making comparisons. So when we think about formula or artificial milk feeding, that presents risks in comparison to breastfeeding. Maternal or birthing parent risks of not breastfeeding include increased rate of breast and ovarian cancer, type 2 diabetes, metabolic syndrome, and more challenging return to pre-pregnancy weight. For your child, some of the risks of formula feeding can include higher rates of childhood asthma, allergies, ear infection, diabetes, obesity, leukemia, and sudden infant death syndrome. Breastfeeding is green. There's essentially no carbon footprint from breastfeeding your baby, and a considerable one when getting formula from international manufacturers. Breastfeeding is also very convenient. It's portable food anytime, anywhere, day or night, with no preparation required. It doesn't take much to get started with breastfeeding. There may be a few tools that could help you be successful. First is a cozy space where you'll be comfortable feeding baby and having extended newborn snuggles. That might be in a favorite rocker or a comfy corner on the couch. Having some supplies within arm's reach is also helpful. Things like baby care items, nipple cream, and nursing pads, if needed, will be easily accessible without having to get up. It's also a great place to stash some snacks for the breastfeeding parent who often forgets to eat and may be extra hungry while producing milk for baby. If you have a friend or family member who offers to make food, a great suggestion are muffins or energy balls that can be stored in the freezer and ready to go for a quick refuel. Don't forget to keep a nice big jug of water handy to replace the fluids that go into making breast milk. Being even just a bit dehydrated can make you feel more tired. The photo on the bottom left is a thorough example of things you may need to support breastfeeding, but is certainly not what you need to get started. You may never need many of these things. So your initial milk is called colostrum, and it's truly a superfood. We like to call it liquid gold. It's usually produced in your body somewhere midway through your pregnancy, and you have it until your body transitions to more mature milk. It's a low volume but very highly concentrated fluid, and this is all baby will need to fill their belly in the first few days. Babies are really good at getting this out when they're latched on, and sometimes we may suggest using your hand to squeeze out some extra drops when you're feeding baby as well. At this stage, it's easier to get this milk out with your hand and not a pump. Your colostrum is full of antibodies, which are essential for your baby's immunity. It gives a protective coating to that digestive system and aids in healing and growth. At the IWK, we promote prenatal colostrum collection starting at 36 weeks in low-risk pregnancies. This next video from the More Milk Sooner team gives a great explanation of the benefits of this practice. Be sure to talk to your provider about whether it's suitable for you.
Hello, my name is Nada Hawkins, and I'm a nurse and lactation consultant, and here to discuss the concept called prenatal hand expression of the breast with you. And so you probably have found us because maybe you've even heard of this before, or maybe your doctor's suggesting it to you. But I want to just take a few minutes to talk about why we find it so helpful. So prenatal hand expression is essentially using your hands to start the process of milk making, and when possible, collect a little bit of colostrum. So this does several things. It activates milk making cells within the milk ducts, so that if something does happen, not ideally around labor and delivery, and you don't have good stimulation in that first hour, you still have good production. The other thing that it does is that if we have baby needing any support with perhaps some supplement, we have the best supplement on earth in the form of frozen colostrum. So not everyone can do prenatal hand expression. There's a list of who should not do it on our website, but in general, what we say is low-risk pregnancies, and this is something you'll discuss with your doctor, can do it, and what we suggest is from 36 weeks on. So at 36 weeks, you're going to just be doing 5 minutes in the shower once a day, and then the actual harvesting of the colostrum happens from 37 weeks on when you're actually producing a little bit more. What we have found is that it really helps mums to transition their milk a lot sooner. We're seeing less sore nipples because baby has the food to actually learn their job with. So there's lots of very cool benefits to this. Your OB might also be encouraging you to do hand expression for the cervical ripening benefits. So every time you do hand expression of your breast, it releases oxytocin from your pituitary. Oxytocin is involved in making milk, and it's also involved in softening the cervix. So if you think to your labor and delivery classes, we have to stretch that cervix all the way out to 10 centimeters. And so I always say, think of if it is easier to stretch a rock, or if we could have bubble gum and stretching it to 10 centimeters. So the oxytocin release that happens with the hand expression sometimes has really positive changes on the cervix as well. So even if you're not maybe considering breastfeeding, your obstetrician might be considering you for this because they want to help you along.
Your milk is constantly changing. It can be different from the beginning of a feed where it may be more watery and thirst quenching to the end of a feed where it contains more fat to help baby grow and gain weight. Your milk also changes to meet your baby's unique needs as they grow. There will be days when you notice that your baby demands more frequent feedings or cluster feeds. This could be very soon after the last feed, and it may make you worried that they're not getting enough. This commonly happens when your baby goes through a growth spurt. It's completely normal and is Mother Nature's way of sending the message to your body that baby's belly has grown and you need a higher volume of milk to fill their belly. The most productive thing you can do on these days is respond to your baby's feeding cues, and it may mean that other things have to wait. It's a great time to snuggle in with baby and catch up on your favorite TV series or watch a movie. Growth spurts usually happen on day 3, 7 to 10, somewhere in the 2 to 3 week mark, 5 to 6 weeks, and around 3, 6, and 9 months. You'll have this day or two where baby's feeding often and then your body responds by making more milk. If this cluster feeding happens for more than a few days, you may want to reach out for breastfeeding support to ensure that baby has a good latch and is able to transfer milk from breast to their belly. We're now going to move on to birth in the early days and what to expect. Now that we've talked about how amazing your milk is and how it changes to meet your baby's needs, we're ready to talk about the first step of breastfeeding, which is skin-to-skin contact. From the moment your baby is born, they want to be close to your heartbeat, just like when they were in your tummy. This will always calm them and make them feel safe and at home in the early hours after birth. Skin-to-skin care helps settle their breathing, temperature, and heart rate. It's also been proven to lower baby's pain experience while having procedures such as blood tests or injection, like the vitamin K shot given shortly after birth. At the IWK, we support the golden hour, which is uninterrupted skin-to-skin contact for the first hour after birth. All routine checks on baby can be done in skin-to-skin care. In the first few hours after birth, we want to promote that early skin-to-skin contact when baby's bright and alert. Often by about 30 minutes of age, they start to show early signs of interest in suckling by bringing their hands to their mouth and rooting. Their first feed's often followed by a long sleep, and then we'd encourage feeding if baby's showing any cues or signs, or on average every 2 to 3 hours, which is a minimum of 8 feeds in 24 hours. Skin-to-skin is still encouraged beyond that first few hours. Babies use smell to help them learn breastfeeding, and keeping them close and waiting for a few days until they have their first bath will help get things off to a good start. Oftentimes, on that first day after birth, baby's kind of sleepy and the birthing person is usually more awake and alert, which can be the result of that adrenaline rush after you have a baby. Often the second night can be a bit more of a challenge for parents. Unfortunately, that adrenaline that kept birthing parents awake and alert is worn off by the second night. Babies are more alert and wanting to be held and fed, being close to the familiar scent and heartbeat of a parent. They may not settle well between feeds and will demonstrate cluster feeding pattern, which is Mother Nature's way of signaling to the breastfeeding body that baby's here, and the body can begin to transition to full milk production. Sometimes parents feel like they don't have enough to feed their baby, but this is completely normal behavior. Keeping them skin to skin and feeding them whenever they cue is really helpful. Letting baby fall asleep at the breast after feeding, and once they're in a deep slumber, they can be placed in a bassinet or handed off to your support person for more skin to skin. This is when the birthing parent can get that much needed rest. But also when they're skin to skin with that support person, they can notice those early signs and cues of feeding, and we'll talk about those later. This is a common time to want to supplement, but skin to skin and responsive feeding is the best way to signal and stimulate milk production. At this stage, your baby can't speak, but you'll become familiar with the ways that they're communicating with you through their behaviors or cues, which are nonverbal ways of telling you what they need. There are specific cues for when they're hungry and when they're full. Hunger cues are classified as early, mid, or late cues. It's helpful to recognize the early signs like stirring and mouth opening and rooting. They're easy to spot when your baby's close and skin to skin. When you get to the late cues, such as crying or arched back, your baby will require a little TLC, maybe some skin to skin and calming techniques before they'll be able to latch on. Just as they show signs of hunger, babies can also show signs of fullness, which can include a relaxed body position, sleepiness, unclenched fists, and disinterest in feeding. This baby is a great example of what we would affectionately call milk drunk. Her limbs are relaxed and she has obvious signs of successful milk transfer to her mouth and belly. She'd likely fall right back to sleep if she was burped. This hungry and full comparison of hands is also an easy way to remember the cues for hunger and fullness. Breastfeeding parents often ask how they will know their baby's getting enough because they don't see and measure how much their baby's getting. There are many other ways, in fact, to see that your baby is getting enough, including a dirty diaper count. How many wet and dirty diapers are they having in a day? You can compare it to the chart in the Breastfeeding Basics book available on the Nova Scotia Health website. Are they giving hunger cues when they're hungry and showing signs of fullness at the end of a feed? Do they settle and sleep well between most feeds, keeping in mind that cluster feeding behavior is normal during periods of growth spurts? Are you hearing frequent gulps and swallowing? And is baby gaining weight when they're having their checkups? All of these signs are really helpful in knowing and reassuring that your baby's getting enough. We're now going to move on and discuss positioning and the latch. So the latch-on is a very important part of ensuring your baby's attached correctly and then can properly suck and swallow. There's a mnemonic called CHINS that lists some reminders for when you're latching your baby. So C stands for close. Baby needs to be close to mom so that they can scoop enough breast into their mouth. H for head free. Baby needs to be able to tilt their head back when attaching to the breast. This allows their chin to lead as they come onto the breast. I is for inline. Baby's head and body need to be straight in a line so that they don't have to twist their neck, and this makes swallowing easier. Nose to nipple. The nipple should just be below baby's nose. As they root, they tilt their head backward, and the nipple will slip under the top lip, moving up and back to rest on the soft part of the baby's palate at the back of their mouth. S is for sustainable. The position should be comfy for both mom and baby for the duration of a feed. Don't worry too much about positioning. This will come as you get to know your baby. This image is a great example of ear, shoulder, and hip alignment when a baby's feeding. And you can see that sucking and swallowing would be easy for this baby in this position. It can be done in other positions, but this is just one way of seeing that connection between ear, shoulder, and hip alignment. These two illustrations are a great comparison of an ideal versus a poor latch. In image number 1, you can see the nipples drawn deep into baby's mouth, so the tip of the nipples touching the back palate of baby's mouth and not getting damaged by the gums or the lips. Sometimes there's some slight tenderness as the nipple gets moved into that deep position. The deep latch enables baby to transfer milk from the breast to their mouth. Whereas in image 2, less milk flows because the latch is not deep enough to massage the milk ducts and transfer the milk from breast to baby's belly. The shallow latch in image 2 will actually damage the nipple and cause pain. The latch should feel like a strong tug and not a biting sensation. If you think there's a biting sensation, it's best to remove baby from the nipple by putting your pinky finger in the corner of their mouth, breaking their seal on the nipple, removing them, and then repositioning and trying again. To further illustrate this concept, we're going to share this video from the NHS in the UK that helps you visualize the desired deep latch.
If your baby doesn't attach properly, she may not take enough breast into her mouth. Your nipple will rub against the hard part of her mouth at the top. You may get sore, and your baby may not be able to take enough milk from the breast. She may seem hungry all the time or not gain weight. Also, a build-up of milk in your breasts can be a cause of other problems, like mastitis. You can avoid difficulties like these by ensuring that your baby attaches well at the breast. To do this, bring your baby's nose directly opposite the nipple. Then let her head tip back a little so that her top lip can brush against your nipple. This should help her open her mouth. When her mouth is open wide, bring her to the breast with her head tilted back and chin leading. Your baby can then take in a large mouthful of breast, not just the nipple. The breast will be drawn deep into her mouth, so your nipple will go all the way back to the soft part of her mouth. Your baby will be able to take all the milk she needs, and you won't get sore.
There are a number of different nursing positions to help make breastfeeding comfortable for you and baby. So depending on whether you're sitting or you're resting, certain positions may be easier than others. And sometimes baby may prefer a certain position on one breast and then another position for the opposite breast. We encourage you to try them all and see what works for you. Milk begins to transition from colostrum into mature milk 2 to 4 days after your baby's born. You may notice your breasts start to feel heavier and they may feel lighter after your baby empties them with a feed. Your nipples may feel a little tender, so you can use colostrum or nipple cream to help with that discomfort. You may also start to hear more frequent sucks and swallows. Babies still want to feed often, but they may settle and sleep well between feedings. And because they're taking in more milk and air with these frequent swallows, remember to burp them after feedings. Babies do a lot of eating and growing in the first few weeks after a birth, so your nipples will likely get a little bit tender and may even feel painful. It should only feel that way for the first few seconds while the latch is getting established, and it doesn't last forever. If it continues, try latching again or try a different position. If baby's crying or you're having trouble getting latched, place your baby skin to skin. This will help you guys reset, calm you both, and then you can try again. Interrupted sleep may be a new experience for you, so it's important to recover your sleep if possible. One way of doing this is to continue to stay in bed in the mornings until you both feel rested. At this young an age, typically babies fall asleep after feeding, so if they're asleep and you have the option to do so, it's a great way to recover. When your milk comes in, you may have trouble latching if your breasts are really full. This is called engorgement, and it's a combination of fullness and swelling of the milk ducts along with excess of fluid in the surrounding breast tissue. It can be normal, but full breasts can be painful, sensitive, and sore. Breastfeeding frequently can help, and if breasts are really full and difficult to latch, try gentle expression to relieve the fullness. Cold packs can also help to relieve pain, and ensuring babies latch deeply and transferring milk from your breast is also important. You'll hear lots of swallowing if they are. We're now going to share a quick instructional video on reverse pressure softening, which is a technique to help soften the nipple and areola to help latch baby on an engorged breast.
Hello, it's Anne Bruce here. I am South Cumbria Breastfeeding Support's IBS-CLC and a breastfeeding counsellor with the Association of Breastfeeding Mothers. And I'm just going to show you a little technique called reverse pressure softening. It's a fancy name for something really, really simple, and it can be very, very useful if you're feeling engorged. If you're feeling engorged, it can be harder for baby to get a deep latch because your boob's too hard. So what you can do is just soften up this area. The coloured bit around your nipple, it's called the areola. You get all the fingers and thumb of one hand and you put them around the nipple, so on the breast, around the nipple, and you press into the chest wall for about a minute. So that's 6 rounds of happy birthday, I think. Just hold like that, and you might leak a little bit while you're doing it, and that is totally, totally normal. The idea is that you do this just before you're about to latch baby on, and it softens up this area just around the area, just around the nipple. If you like, you can put your fingers more on where baby's chin is going to be, and that can just soften that area up so that baby can get a really good mouthful coming from the chin side of the boob. So there we go. That's one way of doing reverse pressure softening. You can do it like this as well, or press in like that, whatever works for you. But the idea is just to soften up the area around the nipple so that you can then get baby latched on to have a deep, effective feed, and then feed frequently to avoid getting engorged again. Bye for now.
We are now going to review some of the more common challenges that can occur with breastfeeding, starting with blocked ducts, or as they're now being referred, ductal narrowing. They result from inflammation and swelling in the tissues that surround the milk duct, which causes it to narrow. It can be very painful or feel like a lump in your breast. Some strategies to help relieve the inflammation are to use cold compresses, continue to feed baby on cue from both breasts, and to use anti-inflammatory medications to decrease the swelling, like ibuprofen. You generally otherwise feel well except for in that one spot. Mastitis is a condition caused by prolonged inflammation of the breast tissue and can sometimes turn into a bacterial infection. Treatment for inflammatory mastitis should be the same as for narrowing, which includes cold compresses, continuing to feed baby on cue with both breasts, and the use of anti-inflammatory medications. Often you can feel a little unwell and feverish. If you begin to have worsening fever or symptoms over 24 hours, it's advisable to see your primary care provider as you may need treatment in the cases of bacterial mastitis. A shallow latch can create significant discomfort and tenderness to the nipple, but it also can be an easy fix. So to start, try positioning baby, bringing them in a little bit closer to you, and if that doesn't help, break the latch, reposition them, and try again. You want to make sure the baby has a large amount of nipple and areola in their mouth to move milk properly and transfer it from your breast to their bellies. Remember the NHS video we showed earlier in the class to help visualize that deep latch. So the next issue we'll discuss is low milk supply. And we just want to throw out the idea that with true low milk supply, you'll likely see a baby that's having trouble gaining weight and might have decreased diaper output. Many breastfeeding parents worry about supply volumes. But if your baby is nursing well and you're hearing lots of swallows, and they're resting well between feedings and gaining weight, then it's not likely a low supply issue. And keep in mind, you don't necessarily have a low milk supply if your baby's nursing more often or fussy during a part of the day. It could just be a growth spurt. As we discussed earlier, if baby's belly grows and they're needing a higher volume, then they'll have a day or two with cluster feeding and increased frequency of demanding. That sends a message to your body to make a higher volume of milk. And also, the volume of milk that you have and produce changes throughout the day, and this is normal. You may notice this particularly if you're pumping and you're seeing smaller volumes at certain times. One of the best things to do to help maintain a good supply of milk is to keep baby close and feed them often. If you're concerned about true low milk supply, you should reach out and get help from either your public health nurse or your primary care provider, or even a private lactation consultant. Thrush is a yeast infection of the nipples, which can create soreness or pain with feeding. It can also be spread to baby's mouth, tongue, and cheeks, and can appear as a spotted white coating. Additional symptoms can include an itching or burning on the nipple that appears red, shiny, flaky, or rash-like, cracked nipples, shooting pains in the breast during or after feedings, intense nipple pain that is not improved with better latch technique or change of position. It is safe to continue breastfeeding with thrush, but both baby and breastfeeding parent will need treatment, so this will require a visit to your primary care provider. Pumping isn't a requirement of breastfeeding, and it often adds extra steps in the feeding process. However, there may be reasons why you may still want to or need to pump. If you're considering purchasing a pump, it's good to think about why and how often you'll be pumping. In general, we would recommend that breastfeeding be well established before pumping and offering baby milk by bottle, and this is usually at around 6 weeks of age. These, of course, are recommendations for healthy term babies, and recommendations would look different for premature or unwell newborns. Breast milk storage guidelines are located in the Breastfeeding Basics Handbook, which is available online, and the link is provided in your class email or the comments below. Self-care has been a theme throughout this class, and we would strongly encourage it being a priority for both your physical and mental well-being. This includes ensuring you're getting enough water, healthy foods, and you continue to take your prenatal vitamin as long as you're breastfeeding. And as always, have a quick snack on hand on those busy days. For more information on wellness and self-care, please refer to the Wellness and Pregnancy video that's linked below. So just a few reminders as we send you along on your breastfeeding journey. First off, So most people hear breastfeeding is natural and you equate that with being easy or with little effort. True, it's natural, but so is walking, and that took some time to master. Breastfeeding with confidence could take days, weeks, in some cases even months until you're confident and baby's doing well. Be patient with yourself, your baby, and your support people, and celebrate the little wins or daily successes that bring you closer to your breastfeeding goals. And keep in mind, sometimes breastfeeding can be a bit of trial and error. Baby may or may not like a certain position, and that's okay. Just roll with it, see what works, and get to know your baby. And lastly, there's a lot of information online from friends, forums, and whatnot. There's a lot of advice that's intended to be helpful, but we all know sometimes it is and sometimes it isn't. You know your baby best, so trust your instincts. So there are a number of community resources that are available for breastfeeding parents in the community. So first off, the IWK Postpartum Follow-Up Clinic sees patients for up to 10 days after birth. And then Public Health is also available, and you can self-refer to them with the number that's attached here. Your primary care provider, family doctor, midwife, nurse practitioner, they're available as a support to you as well for breastfeeding goals. There are private lactation consultants in the community. If you have a doula, sometimes they do provide postpartum breastfeeding support as well. The latch League has a rich resource both online, and there's lots of groups that meet and supports that are available virtually as well. You can check out the Breastfeeding Community of Practice website that lists a number of resources. Don't forget your friends and family, people who have breastfed before and may be able to give you some help. And your local family resource center is also great. They often have breastfeeding classes or breastfeeding supports within the Family Resource Center. So that's just a few that are listed. There are also a couple of community breastfeeding clinics in HRM as well that you can see those resources on IWK Pregnancy Instagram, or you can reach out to your family doctor for that information. So on behalf of our RBC team here at the IWK, we just wanted to thank you for taking the time to watch this video. A little bit about our team. Well, we came together for you. We're passionately committed to make the changes needed to ensure birthing persons and their families feel safe and supported about their care and their experience here at the IWK. So if you have any feedback for us, we'd be happy to hear from you. You can email us or send us a DM on Instagram at IWK Pregnancy. And once again, congratulations on the upcoming birth of your baby, and we wish you all the best on your breastfeeding journey.